Good afternoon, everyone. We'll get started if it's okay with everyone. So I just want to introduce myself. I'm Muriel Grande. I'm at Rutgers Cancer Institute in New Jersey, and I have the distinct pleasure of introducing our state-of-the-art speaker, Dr. Leanne Feldman from McGill University. She's the Edward W. Archibald Professor and Chair of the Department of Surgery at McGill University and the Surgeon-in-Chief at McGill University Health Center. Her clinical focus is minimally invasive gastrointestinal surgery, and her patient-centered research program focuses on improving quality and outcomes of abdominal surgery. She's established a multidisciplinary group implementing evidence-based enhanced recovery perioperative care plans at McGill University Health Center, which was recognized as a leading practice by Accreditation Canada. She has several international roles and is involved in several surgical societies, including SAGES, as well as the American College of Surgeons, where she co-chaired the Enhanced Recovery and NISQIP Collaborative. And so, without further ado, I'd like to take this opportunity to, on behalf of the HPBA, to warmly welcome Dr. Feldman as she gives the state-of-the-art lecture on preoperative patient selection and optimization.
Thank you. It's really a pleasure to be here with you this afternoon, and it's been fun to be a guest at your meeting and see the amazing things that are going on in HPB surgery. So what I'd like to do really in the next 30 minutes or so is talk about moving from risk assessment, so this kind of okay for GA, okay for OR, to really risk optimization and a strategy for that, which is prehabilitation. So basically starting to rehabilitate people before surgery. I don't have any disclosures, but I would like to, right from the start, acknowledge the work of Dr. Franco Carli, who's a prehab guru, the prehab whisperer at McGill, and a lot of the work that I'm going to show you. And he's an anesthesiologist. He's a previous chair of anesthesiology at McGill and has really championed this work. So what I'd like to do today, and we've had a lot of discussion at this meeting already about quality and improving outcomes. And we've seen the impact of complications on, we've talked a lot about that as well. So what are we missing? What are we missing in improving quality and outcomes for these complex patients? I'm going to talk about the concept of functional reserve and how we can measure that, what that is, and how we can measure it preoperatively using functional status to measure that concept of reserve. And then I'm going to talk about prehabilitation in a little more detail, some of the evidence, including some of the evidence in HPB surgery, which is probably a great area for future investigation or present investigation, a little bit of knowledge gaps and opportunities. So when we heard about a lot about this at the meeting yesterday with your President Doyle's talk, and when we've asked surgeons in the past what they consider important in their patients' recovery, they say complications, right? Just like we've heard about. These are very impactful. We've had some great panels about that. And in your field, of course, they're very common. They're very prevalent. Pancreas surgery, complications 44% for cancer resection, and death mortality of 4%. Liver surgery for primary metastatic disease as well. Very high morbidity and high mortality, and that sticks with us. When we go and we've asked patients what they consider important in postoperative recovery, I've never heard the word complications. It doesn't mean it's not important, but they certainly don't say length of hospital stay. That one never comes up in interviews with patients. What they consider important, and this is a work that we were able to do internationally because of the pleasure of having international fellows who then go back and are able to help us do studies. And we've interviewed patients from all over the world during their recovery from major abdominal surgery. They tell us that what's important to them in recovering from surgery is functional status, returning to their normal habits and routines, regaining independence, overcoming the mental stress of surgery, having symptoms resolve, and really getting back to enjoying life. And the thing is that functional recovery, even though it's important to patients, we're not doing so great on that metric. So if we look at persistent disability 6 months after surgery, this is a great study. It's about 20 years old now, but and these were in older patients where they measured functional status with a variety of metrics. 20% of older patients after major abdominal surgery, and this won't be a surprise to you, are still not back to baseline for IADL. So that's ADLs plus things like managing finances and doing housework. And if you use more complex measures of functional status, like walking tests or muscle strength, 30, 40, 50, 60% of patients are not back to baseline, even 6 months after surgery. And what are risks for poor recovery? This is where the complications meet. What we think is important meets what patients think is important. Is complications are the most important factor in delaying recovery. And after that, for the surgery is also a huge risk factor for recovery after surgery. So if we wanted to look at that as a model, and we look at on the y-axis some kind of measure of functional status, and there's lots of ways to measure that. We like to use walking tests for that, 6-minute walk distance test for that, very simple test. And we know that below a certain level of functional status, a person is not independent anymore. We know that with the metabolic stress of surgery, that there's an acute drop in functional status. Traditionally, that's when we keep people in hospital, and then a slow return back to baseline over weeks to months. And where complications fit in, of course, is that it will delay that period of recovery. So when people have looked at least for colectomy, we all heard about the impact of complications and how we blame ourselves and how we have the little cemetery in our head that we never forget, or we have the bracelet that we pray to basically in our car before cases. But when we look at what is actually responsible for the variability, we know there's lots of variability between hospitals, surgeons, regions in outcomes, at least following a colectomy surgery. The greatest contributor to complications is actually patients, the patient factors, with a much smaller contribution to the variability in outcomes from surgeons or hospitals. So even if you have if you take your most comorbid high-risk patient and you are the best high-volume surgeon with the best outcomes, and you are working in the best hospital with the best outcomes, you will still have a very high chance of complications, because the majority of the risk for that's explaining that variance is coming from the patient. So who are these patients? Who's at risk for complications? We think we know it when we see it, right? When you're in your clinic or you see those patients, those are those patients, maybe they're a bit frail, a bit slow in walking around. They seem to have poor functional status. They're older patients, lots of comorbidities, obese. We were doing a study, traditionally I would have thought of HBV patients as being more on the sarcopenia frail side, but we're doing a prehab study right now. 60% of the patients are overweight or obese. I know this isn't news to you, but it wasn't the picture I necessarily had in my mind. They have cancer, obviously. They're getting neoadjuvant therapy. So those are the patients that, we say in our mind, unfit for surgery, or the pre-op clinic says unfit for surgery, unfit for GA. What that means is really that we think those patients have limited physiologic reserve. So what is this concept of reserve? The reserve is the difference between maximal capacity, so what a person can do when really stressed, and basal performance, so what we do in everyday activities. And this represents this margin, the safety margin that may be needed to meet the increased demands for cardiac output, carbon dioxide excretion, protein synthesis, immune responsiveness, et cetera, that we know is part of this metabolic response to injury and to major surgery. So we know we remember chapter 1 from Schwartz, or whatever book or website is used to learn surgery, but we know that we have that metabolic, catabolic response to surgery. And you can see that with age, basal function doesn't really, basal capacity doesn't really change very much, but that a maximal level is very variable. And even patients who look like they are below their stated age will still have that decrease in the maximum function, so a decrease in reserve. And we've all experienced that or noticed that clinically. So the best way, the gold standard way of measuring exercise capacity is with formal cardiopulmonary exercise testing. So you get somebody on a bike or a treadmill and they exercise to volitional exertion, and you measure oxygen uptake. And this is just in very small writing, just to give you an example that there's a lot of data that shows the strong association between measures of exercise tolerance established in this way and outcomes complications, particularly cardiac complications and death. And you can set out different thresholds based on different tests on CPET testing, like oxygen uptake at anaerobic threshold. We don't have to remember the numbers, but just that there are basic numbers that have been established where those are thresholds for increased risk. So what about the concept that we know these patients when we see them, right? So, and this is, this is the, can you get up 2 flights of stairs question? Who uses that question for risk assessment as their main risk? Yeah. So that's the people that can get up 2 flights of stairs. That means they can reach 4 metabolic equivalents, which is roughly 14 mils per kilogram per minute VO2 peak on formal exercise testing. And guidelines like this one from the American College of Cardiology says that patients who we subjectively think can get above 4 METs don't require any other preoperative testing. They can go right to surgery. So this is a study in the Lancet. It's relatively recent. It's called the METS study. It was a large international prospective study that said, oh, how good are we at this subjective assessment of METs? Remembering a METs of 4, meaning safe to go to surgery. Well, actually, we're not bad at picking out the patients who actually have very low fitness. So if we said that somebody had less than 4 METs, so low fitness, those patients were more likely to, when you put them on the bike, to actually have low fitness. But the sensitivity for that is very low. And actually 84% of the patients that the perioperative physician said they could get up 2 flights of stairs, their METs were greater than 4. 84% of those patients, when you put them on the bike, 84% of patients with low fitness on the bike were classified as being okay, as having METs greater than 4. And actually, the patients we said were at risk, like they couldn't get up 2 flights of stairs or because their METs were less than 4, actually that did not predict any complication, death or complications or cardiac morbidity. So you can stop asking patients if they can get up 2 flights of stairs, so that you can, that's one of my take-home messages for you today. So this subjective thing of we know it when we see it probably doesn't hold up. So what can we do? Most of us don't use formal cardiopulmonary exercise testing. They use a lot of it in the UK for risk assessment, especially to decide who should go to sort of a high dependency unit or a step down type of unit. But the good news is that you can use a simpler test that correlate, at least in surgical patients, with formal cardiopulmonary exercise testing, like 6-minute walk distance, where you get a hallway and you get your stopwatch and you tell somebody to walk at a pace that they'll be tired a bit at the end of 6 minutes, and you measure how far they went. And actually, and these are colectomy patients, but in these patients, there's a pretty good correlation with formal exercise testing with VO2 peak and increase in walking distance. Patients that walk more have lower risk of complications. And a cutoff could be around 400 meters, where that seems to be a threshold for the walk test. And there are a bunch of other tests that you can use. DASI is a good questionnaire, the Duke Activity Status Index. DASI score, it's 12 items, very quick to fill out, less than 34 is a good threshold for patients to identify patients at risk as well. So if we know from these kind of risk assessment questionnaires, walking test, formal testing, we know that low preoperative functional exercise capacity or reserve is associated with death, complications, prolonged recovery, longer length of stay, discharge destination, and of course costs. So the question is, well, what can we do about it? So we're doing that already. We've got that risk assessment, and it informs conversations with patients, maybe shared decision making. But can we do more? So that's where the idea of prehabilitation comes in. I don't know if you've seen this great Nike. I have no conflict of interest with Nike, but this is a great commercial about Sister Madonna Booter, who ran Ironman triathlon at the age of 82. I mean, not sprint triathlon, like an Ironman, a full Ironman. So the question is, she's trained at older age, obviously, to that incredible endurance event. So can we train patients to improve fitness, improve reserve before surgery? And will that have an impact on some of these outcomes? So that's the concept of prehabilitation. So, starting your rehabilitation before the surgery and moving a bit from risk assessment to risk optimization, and really to use the preoperative time to optimize the physical, functional, nutritional, emotional, medical conditions of patients and increase reserve in anticipation of this upcoming metabolic stress, with the intent to decrease morbidity, return to intended oncologic therapies, improve functional recovery, and maybe even improve long-term health. And so as part of our model, the idea there, of course, is to increase this functional status before surgery to give reserve, increased reserve to tolerate the metabolic stress of surgery. So the concept here is that when we think about patients recovering after surgery, we can start thinking about that as beginning even before the surgery. So a big component of prehabilitation is exercise. And I want to just differentiate a little bit between physical activity and therapeutic exercise. So physical activity is telling patients to go walk some more, and maybe get a pedometer and meet a certain number of steps. And that's all good because that's increasing physical activity, versus therapeutic exercise where it's really targeted. It's targeted on a deficit and it's actually prescribed. And chronic exercise, you can see, we're not talking about acute exercise where you got to run and get the bus, but chronic exercise over a period of a few weeks, and only takes a few weeks, increases aerobic capacity, decreases the ratio of lean body mass to body fat, decreases sympathetic overreactivity, improves insulin sensitivity, remembering all of those as pretty much the hallmark of our metabolic surgical stress response to surgery and injury, and also all the things we do to patients around surgery or they have done to them, which is a lot of staying in bed, lack of physical activity, poor nutrition around major GI surgery. So we can see that there is a potential, makes a lot of sense to think about improving, using exercise to improve fitness before surgery. So I'll tell you a little bit about our experience with this, again, led by Franco Carli. We've done a few trials in this area starting about 15 years ago. So this was a trial in colorectal surgery where we took patients, they were randomized to either in pretty high intensity cycling program. We went to their house, we built them a bike and gave them the program. And then we needed a control group, and the people helping us design the trial said, well, the control group can't be nothing. And we're like, but that's what we do nothing. They're like, no, it can't be just nothing because you have to account for the increased attention that you're going to give these patients in your in your intervention group. So we made up a sham intervention, which was a recommendation to walk and do some kind of really old-fashioned physiotherapy exercises like moving their ankles around and breathing exercises. And this went on for a little bit over a month, and we used our 6-minute walk test as our outcome. Well, actually, it was a total failure. It's amazing that we even got this published. The exercise group did worse than the walking group. There was no benefit of the prehabilitation whatsoever. And actually, post-op, they had poorer recovery in the bike group. Thank you. Goodbye. No, that's not the end of the story, but that was the first trial. So when you get results of an experiment like that, you either say, well, this doesn't work, or you try to figure out what happened, because we were big believers in this. Adherence was very poor. It was 15%. So basically, neither group got much of anything. Maybe biking in this rectal cancer group was a bit too intense. Nothing addressing nutrition or mental anxiety, depression. We didn't have an ERAS program at that point, and we didn't continue in the post-op period. So we went back to redesign a multimodal program that also was strongly based on exercise, aerobic resistance and balance, but also involved a nutrition intervention, which even for patients who are not poorly nourished or have malnutrition at baseline, using protein to increase the impact or effect of exercise on building muscle mass, which especially as we get older is very important. And also some relaxation component and component about trying to increase adherence, as well as, embedding this in our pre-op programs, where other aspects in the past few years have been more and more recognized as being very important: anemia, glucose control, smoking cessation, and so forth. And then embedding this obviously as in ERAS or enhanced recovery. So this is really the preoperative part of ERAS. And now when we repeated a trial, this time we changed our design a bit. So it was prehab versus rehab. We either started the program before surgery or started it after surgery. Now we see more like what we wanted to see with our model. So on the again with the 6-minute walk distance as our outcome, and you could see that before surgery in the solid line that patients who got the prehab intervention, half of them improved in their 6-minute walk distance, whereas actually patients, and there's good data in hepatobiliary surgery patients, really do decline in waiting for surgery or in that preoperative period. And the patients who got the prehab program were more likely to be recovered back to baseline in 2 months after surgery. The duration of prehab in this case was 3.5 weeks, and the compliance was a lot higher, 70, some 80%. And there was no difference in length of stay, no difference in complications. And we've repeated that for various other procedures. This one is probably closest to what you guys do. So esophagectomy, pretty high intense procedure with lots of complications. And these patients, a lot of these patients, the vast majority of these patients were undergoing neoadjuvant therapy during the prehabilitation period. And you can see the same kind of pattern with that decline in functional status in patients having especially in patients having neoadjuvant therapies, and that the prehabilitation intervention could mitigate that and maintain, in fact, improve patients even despite neoadjuvant therapy. Again, no difference in length of stay or complications, of course, in this kind of procedure are very high. Similarly, this is cystectomy, another, very high morbidity, high morbid procedure. And again, we see a similar pattern with improvement in functional measures. These are all with 6-minute walk distance, and no difference in complications or length of stay, but with higher protocol adherence. And again, 3 to 4 weeks duration of prehabilitation. So in our studies, in single center studies, we haven't shown differences in length of stay or complications. This is a very active area of investigation. So this is an umbrella review of reviews. It's a systematic review of systematic reviews. They found 55 systematic reviews just in prehabilitation. That's like twice as many as randomized trials as there are. So that shows you people are interested in this, but we need more people doing probably the studies. And the bottom line was that when you put all those studies together, there's low certainty evidence, though, that prehabilitation improves complications, but it's protective against complications. And for functional recovery, there's moderate certainty evidence that this improves functional recovery, which, as I mentioned right at the top, is an important outcome for patients. There's lots of gaps in this literature. So the optimal approach to patient selection, the intervention, what kind of exercise, how intense it should be, the duration, how to get people to adhere with this, and so forth, and whether and where they should be delivered in the community, at home, supervised, et cetera. So there's a lot of questions. But there's a lot of ongoing work on this. This is a year ago. You can see there's a lot of work in Canada. You might say that that's because we have our wait lists and so forth. But as you can see, this is a 3 to 4 week intervention. So it's not, a 6-month intervention. Looking specifically at HPB surgery, you might think it would, with the kinds of patients that you are taking care of, who are at risk for complications and also getting neoadjuvant therapy in many cases, or have, biliary obstruction, getting different procedures. There's probably a very interesting potential role for prehabilitation. There's not a lot of work out there specific in HPV surgery. So this is a systematic review, relatively recent, 6 studies, about 1,000 patients, only 3 RCTs, very few patients in those RCTs. But again, the same kind of pattern that I've described for you in other patient populations. So improvement, it is possible to improve measures of strength, cardiopulmonary fitness, and quality of life, and even sarcopenia. And the studies so far in HPB surgery there's only 3 really high quality studies, have not shown a difference in length of stay, complications, or mortality. We did a trial that's not published yet. Well, we tried to do a trial in HPV cancer surgery, and the feasibility here is tough. It's not impossible, but it's tough. So we had 311 patients we assessed in 4 years. 80% of the patients were excluded right from the top. A lot of times it's because there wasn't perceived to be enough time, but that may be that we're not seeing those patients referred early enough in their trajectory. So you know, you need a few weeks, but some of these patients you're getting referred from the pre-op clinic, which is happening just a week before surgery. So there's some organizational issues that can occur. And of those 311, we ended up with 60 patients randomized and only about 45 completing the study. And I don't have the data to present to you yet. It hasn't been published yet. But it still made it into Prehab for HPV cancer surgery has made it into guidelines. It's in the ERAS Society guidelines, the liver guidelines, with moderate level evidence and a weak grade of recommendation. But it is considered, at least by the ERAS Society, to be promising enough to be considered. How do you make this happen? Again, this is a multidisciplinary team. It includes people that are not traditionally on our team. So kinesiologists, people with, you know, expertise in exercise physiology. It's multidisciplinary, it's personalized, and it has to be modified to when you see the response to the patient and what, you know, what's happened with it. And it's also, we've embedded it in the pre-op clinic. So we can get a prehab consult, you know, from patients that we see in the clinic ourselves. We shouldn't really be waiting to get that patient referred once they're in the pre-op clinic, because at least in our place, that's happening just a week before surgery. And it's more of a, you know, risk assessment type of thing. So if we really want to do this, we have to identify the patients in advance. And we have set out criteria for referral basically, we do the DASI questionnaire in all patients that we see that we're considering surgery as part of our consent process. So the pre-op clinic does have that information right from the top. And so we've set out criteria for a referral. Then patients who are screened, who screen out positive, either from the clinic, the surgeon's clinic, or from when they're seen in pre-op, then get referred and have a formal assessment, usually with CPET testing, with cardiopulmonary exercise testing, other formal walking tests, nutritional assessment with a 3-day diary and a visit with a nutritionist, and a protein and energy requirement estimation, and some relaxation strategies for them as well. And then the program is designed that meets the deficits that an individual patient will have. So it's not a one size fits all. It really depends on what overlapping issues there are, either with lean body mass, with nutrition, and with exercise tolerance. And so it is very risk stratified and targeted. And it's not a one size fits all. Adherence, here's a couple of challenges I want to bring to you. So this is a study from Ottawa that was a negative study in frail patients, so very difficult patients to study, but obviously very high risk for complications. So adherence to prehabilitation was still pretty low. The mean adherence in this study was 60%, and it ranged from 0 to 100%. But you needed 80% in this study, 80% adherence for it to be beneficial, which makes sense. And only 40% of the patients met that threshold. So there's a lot of interest in whether digital applications could help with that, especially with increasing engagement for patients. And there are various evidence-based techniques for doing that, and also helping to integrate this intervention more in the trajectory of care, both outside and inside the hospital. And finally, I want to just end with something that I think is quite interesting, which is that we looked at, this is a material deprivation quintiles. We know that patients with low socioeconomic status are at risk for poorer outcomes, surgical outcomes. And when we looked at our patients that had gone through a bunch of our trials and put them all together, we found that all patients across all of these material deprivation analysis had the same benefits from prehabilitation and improving functional status. But however, patients at the lowest, most material deprived had a lower incidence of agreeing to participate in these trials. So there's work to do in reaching out and making this, bringing this to patients who may have the best chance at benefiting from it. So just to summarize, I hope I've convinced you that patients with low fitness and reserve are at risk for complications and poor recovery, that meaningful increases in fitness can be achieved in only a few weeks and be maintained postoperatively, that this perioperative period is also a teachable moment to make long-term changes. So when we're operating on patients for benign reasons, getting them to stop smoking might be the most important impact on their health than anything else that we did. And this is an important part of enhanced recovery. But this is a work in progress. Prehabilitation is a complex intervention. It's not telling people to go walk some more if we want it to be beneficial. And it can't be done by surgeons and anesthesiologists alone. It requires a multimodal, resource-intensive, tailored, personalized approach that begins well before when we usually have people seen in the pre-op clinic. And this is an opportunity to develop novel partnerships and technologies to prepare patients for surgery and improve outcomes. And I think where there's a lot of work to be done is how to make this sustainable and accessible by transferring this from the hospital to a community setting to address some of those issues. It's been a real honor to have the opportunity to attend the meeting. I've had a lot of inspiration by watching and learning from many of the talks. I really appreciated being here with you today. Thank you.
Thank you, Dr. Feldman. That was great. We'll take any questions from the audience. I actually had a question. So, when we have implemented ERS pathways in our institution, and we're looking to potentially start a prehabilitation program, and we have actually a wellness center across, or really just a gym that's a part of the that's literally right across from the university. And prior to COVID, there was actually a prehabilitation program that had been set up. So, many of these programs require the patient to just do these exercises at home. And, is there some utility to having it done in a gym setting or with, with an actual instructor or not? I mean, obviously that adds cost, but what are your thoughts on that versus being able to easily do it at home?
There's been successful trials both ways. Home-based programs can be successful usually, and our program is actually a home-based program or could be in the gym setting. But I think, maybe a formal assessment, you get a plan, and then it can be done anywhere. It doesn't necessarily, I think having a supervised program 3 times a week is probably not going to be feasible. So I think that does increase the feasibility significantly, and creating these partnerships in the community, I think, is the path to sustainability.
Great, thank you.
So maybe along those lines, Leanne, having a buddy to go through the program with you and engaging family or friends, at least our patient population is devastated by the news, by the diagnosis and on the cancer side of things. I'm wondering if there are any thoughts to incorporate that, or is there any literature where a buddy or family members engaged in doing the program in parallel?
Yeah, I think that's a good point. I don't know of any literature that studied it, but I think that for sure it would be, I can't see the downside. I think anything that addresses adherence would be beneficial. And I agree that I think it's a very good way to sort of transform or reframe a period where somebody is waiting for the next step in their therapy, whether that's because they're undergoing neoadjuvant therapy, because they need other biliary procedures to get to surgery. I think that it's a very good time to engage in something that will be positive. And we've done some questionnaires just to ask the patients and basically, the results are, you never see, 100% of patients appreciate it. 98% of patients, were inspired to continue exercise, so this, no matter what, I think it is very, very well received and appreciated by patients.
Well, thank you so much, Dr. Feldman. As a token of appreciation for your time and your excellent talk, just like to present this to you.
Thank you very much.
Thank you.